calling this meeting to order. If everyone will rise for the Pledge of Allegiance, please.
I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all.
Christine, would you please take the roll call?
Director Danielson.
Present.
Director Wallace.
Present.
Director Stewart.
Present.
Director Nicholson.
Present.
Director Epen.
Present.
We're all here and accounted for. Thank you. Our first education session, our only education session, is the budget.
Before I ask Chris, Henry, and Dan Ardoti to present, I'd like to offer some of my insights about the year to come. I think everybody who works in healthcare is aware that the Supreme Court has a decision pending that will determine the legality of subsidies, which are bedrock to the Affordable Care Act. If they determine that the subsidies are illegal, they will have cut the ground out from underneath that program. I think that what we'll see after that is Republicans and Democrats posturing, each with their own plan, to fix the subsidy issue. And there will be a tremendous amount of confusion that arises from that, and we may actually see no decision made as opposed to a compromise. It could collapse the Affordable Care Act. Even if the Supreme Court ruled that the subsidies are legal, the law provides for only 3 years of subsidies, which would mean a pretty large-scale battle in Congress to extend that 3-year period. Independently of the Affordable Care Act, the Medicare program continues to inflict new rules on physicians and on hospitals. The Medicare Part B sustainable growth rate reimbursement formula that was the subject of so much discussion as we've gone through the past few years, with Congress kicking that can down the road, has been replaced by a new payment system called MIPS. It stands for Merit-Based Incentive Payment System, and it is their new approach to compensating physicians for their work under Medicare Part B. There will be a whole mess of very complicated and changing rules that will accompany this new approach to physician payment, and they haven't published any of the first set of rules yet, so it's hard to predict what hoops the physicians will be asked to jump through. We also have ICD-10 coming in this fiscal year in the fall. They have canceled it twice before. It looks like it's going to go this time. However, some of the insurance companies have announced that they aren't going to switch to ICD-10. They're going to stay in ICD-9. And so we'll have to maintain dual coding systems here at the hospital, as will everybody else, including physicians. There's a cost to the implementation of ICD-10, and we're projecting $7.4 million for our shop, and that's an unfunded mandate. There's also something else that is of enormous concern as it relates to the Affordable Care Act, and that is the fiscal health of the state exchanges that were set up under the Affordable Care Act. The federal government provided $4.8 billion in funding for 13 states that set up their own exchanges. After a year and a half of operations, the money's been spent, and cash flow problems are beginning to be reported. The California Exchange has an $80 million deficit for the first 4 months of this calendar year. Oregon shut down their exchange after spending $248 million in federal funds. Nevada shut down its exchange Hawaii, after spending $205 million in federal funds, asked the state legislature for a $10 million emergency funding, and the state legislature refused to give it to them. So the funding crises of exchanges is also being exacerbated by some insurance companies in multiple states demanding extremely high premium increases, some of them over 50%. The Massachusetts exchange is under investigation by both state and federal authorities who are looking into a purported failure to screen for eligibility, resulting in misappropriation of funds. So the state of the exchanges themselves is a matter of concern. On the good news side of things, we've looked at the Beacon Economics report, and the East Bay economic outlook for 2015-16 is excellent. It's very positive, every indicator. So that's looking strong for us. Our unemployment is below the state rate. They talked about new job creation, and that's being driven by computer systems design and related services. That's the single largest source of new jobs in the East Bay. I think also we have to take into account that we don't exist in a vacuum. We are surrounded by safety net hospitals, and there is much to be concerned about. Lex Ready continues to operate St. Rose under a lease agreement. The operations of that hospital are dependent upon substantial subsidies from the county. 4 of the 6 Daughters of Charity hospitals are located in the Bay Area. Prem Reddy made an offer to purchase them. The Attorney General placed conditions on the sale that caused him to rescind his offer. We don't know right now what's going to happen with those hospitals. Doctors Hospital, the old Brookside District Hospital, closed. And while it seems like it's very far away, it does place a strain on the EMS system for Contra Costa County. And the way they're going to have to meet that is by some of those services being impacted in northern Alameda County. And when they're impacted, it's like a chain reaction. So the absence of that hospital in a community where it's vitally needed ends up being a problem for us down here from time to time. And I think everybody's aware that Valley Care, in the throes of financial crisis, turned to Stanford, who is operating the hospital, and I think eventually will take possession of it in the sense of ownership. And Sutter announced his intent to close Alta Bates rather than fund its seismic replacement. So as you begin to look at these moves and changes, there's no way it doesn't affect us. We've had a very successful 2014 upgrade to our Epic system. It's behind us now, and now we're turning our attention to our new clinical laboratory system, Beaker. And like all the IT systems, it comes at a price. Beaker is projected to cost us $9,947,000. That will happen in the coming fiscal year. In fiscal year 2014-15, we orchestrated a 10.2% reduction in expense. The single largest category of expense is labor in a hospital. And it's of ultimate importance to every one of us that we sustain those reductions over the long run. And as a result, labor expense has been very carefully scrutinized in the preparation of this budget. We have FTE count increases related to volume in this budget. We have staffing ratios we must comply with. They're not optional. We have a few new programs that are coming online, and there is a modest amount of an increase in FTEs associated with those, and they include the palliative care program, the perinatal diagnostic clinic that we'll be working on with UCSF, and the nursing new grad program, because we're finding recruitment a challenge we want to be able to grow our own, and so that is an expense. And then we have the lean promotion office. So you'll see a volume increase of nearly $6.5 million in the budget. We have wage increases related to contracts with organized labor. We also have increases with the FTEs supporting the new programs. Changes in payer mix have radically affected our financial performance. We have experienced a steady uptick in PPO, returning to the pre-2008 levels and above, which is very good news for the hospital. Between 2012 and 2015, there's been a rise from 18.4% PPO to 23.6%. So that is a very beneficial change for us. HMO has declined in the same period from 6.4 to 4.1. And what I suspect is that is the Kaiser draw. Private pay volumes, as we've noted throughout this past year, have been steadily declining while the Medi-Cal population has been increasing. So with those observations, I would like to turn the program over this evening to Chris Henry. I want to give him a formal introduction. This is a very important night for the finance division and for the whole hospital. Chris Henry attained his Bachelor of Science degree from Cal State University East Bay in September of 1995 in business administration with an accounting emphasis. He worked in public accounting for 4 years, after which he was certified as a certified public accountant. He joined Washington Hospital as the Director of Accounting in May 2000. In December of 2003, he was promoted to Controller. Since October of 2006, he served as our Chief Financial Officer. In October 2010, he took on the additional responsibility of being an Associate Administrator. He's a member of the California Society of Certified Public Accountants, the California Hospital Association Healthcare Financial Management Association, and the American Institute of CPAs. He also serves on the California Hospital Association's Advisory Committee and is active in the District Hospital Leadership Forum. Also speaking tonight will be Daniel Nardoni. He's a Senior Director, Budgeting and Ancillary Financial Services. He graduated from Cal State University East Bay, receiving his BS degree in Business Administration with an emphasis in accounting in 1991. He spent 3 years in public accounting with Arthur Andersen, working in their healthcare practice, followed by 5 years with Sutter Health as a senior accountant. In 2000, he joined Washington Hospital as a senior accountant. After 5 years in this position, Dan was promoted to budget manager. In 2009, he took on additional responsibilities as the Director of Budgeting and Ancillary Financial Services, and in 2011, he was made a Senior Director in this same role. He recently completed coursework at the University of California, Irvine, receiving his Master's of Business Administration in Healthcare Administration. So tonight, those are the two representatives from our finance division that will be addressing the board.
Thank you, Nancy. Before I get started, I need to make some acknowledgments because this product that you're about to see isn't just a product that comes out of the finance division. It comes out of the hard work of every manager in this organization, and it's truly a team effort. I'd like to thank the associate administrators, Stephanie Williams, Ed Fayen, Tina Nunes, Brian Welch, and Kimberly Hartz. There's a lot of effort that they've taken in pulling together numbers from their respective divisions, and a lot of nights and days and meetings sitting and going through all this stuff to get it to something that we think is a good budget. So thank you all for the teamwork this year. We couldn't have pulled this together without you. Likewise, all the management team of Washington Hospital, all every manager in this organization has input into this budget. The numbers start with them. So I need to acknowledge all of them and thank them. Dan Nardoni and Nathan Clay. Dan is really the engineer of this process that started back in January. And Dan takes the role of kind of guiding us through each step of this process and making sure that we cover all the bases, and when things look weird, pointing them out and calling us to task. So Dan, thank you. And this year Dan had Nathan Clay working with him for the first time. Nathan is moving into a role to help support the budget process. And so Nathan spent a lot of time crunching numbers and pulling things together for us. So thanks, Nathan. You did a good job this year. Colleen Dorr, my assistant. Wow, I don't know how you do what you do. Colleen's the person who has to get us all where we're supposed to be, when we're supposed to be there, and getting 6 calendars together to get us all in one place at the same time is a challenge, let alone if we mix it up a little bit and get some other folks in there. So Colleen does that, and she produces all the written materials and is really our quality control person and basically keeps us going. So Colleen, thank you very much. And finally, Nancy. Nancy, without your leadership and your vision and your guidance and your trust, there's no way we could get to where we are tonight. So I thank you for that, and here we go. Okay. So we always start with our mission statement, and our budget is really the financial embodiment of this mission, and we don't forget it as we're going through this budget process. It guides us every step of the way. The numbers you see are all driven by the patient-first ethic, and I'd like to point that out because a lot of folks don't quite make the connection between that and finance, but it really is the foundation of our budget, and something that we take very seriously as we go through the process. Nancy mentioned the environment. I'm going to speak a little bit about the environment. This year we were budgeting in a local environment that's been much improved from the past several years, and there's a lot of good news to tell. Nancy mentioned Beacon Economics report that's distributed by the East Bay Economic Development Alliance. In going through that report, there's some pretty key numbers there. In the period, the 1-year period ended February of this year, job creation, the growth rate in jobs in the East Bay was 2.4%, which is pretty strong performance given where we've been over the last several years. They also expect the growth rate in jobs between now and the end of the calendar year to continue at a rate of over 2%. Unemployment in the East Bay, and again, they were looking at the period ended in February, was at 5.1%, down from 5.4% the prior year, and significantly lower than the statewide average of 6.7%. Throughout this entire downturn, the East Bay and the district have done better than the state, and it has a lot to do with the population here and proximity to Silicon Valley, quite frankly. In the district, unemployment was down from 5.4% to 4.1%, and unemployment in the district peaked at 9.7% in December of 2009, so some significant improvement there. And overall, Beacon says that the key economic indicators are all strong, and they don't expect that to change in the long run moving forward. One of the ways Nancy mentioned this, one of the ways that the hospital can see the impact of employment is in our payer mix. And as you can see here, the red line in this graph represents the percentage of PPO volume in our gross revenue. And it tracks pretty closely with the unemployment rate. Back in 2009, 2008 PPO was running at about 22.1%. It dipped down as unemployment continued, and there's a little bit of a lag there, but it bottomed out at about 19% in 2011, and since then has steadily grown we're projecting this year PPO to land somewhere around 23%. So really a good sign for us. Interesting that HMO, as Nancy mentioned, seems to be kind of going away from the market. I think a lot of the insurance companies have found those plans unpopular, and I think a lot of those are going to Kaiser. But even then, if you see between 2014 and 2015, we're starting to see an uptick in HMO. So those are all strong indicators for us. It's good for us. It's healthy for our revenue, and all good news. So lots of good news for us, but we still have a lot of challenges facing us. Some of it's old, some of it's new. This is a very old challenge for us, and that is the fact that government programs, the reimbursement from government programs does not cover our cost for providing care to the beneficiaries of those programs. These are 2014 numbers. This is the last complete year that we have available. In 2014, Medicare reimbursement came short of our cost, not our charges, of our cost, at almost $86.8 million. And likewise, Medi-Cal came short $46.8 million. This has been a long-standing problem, really from the beginning of the program. It is the thing that nobody really wants to talk about in the debate over the cost of health care. This is really a hidden tax that gets passed on through commercial HMO and PPO premiums to consumers. It is a cost shift that occurs. And again, like I said, nobody really wants to talk about this, but it's very real for us, and I'm sorry to say alive and well at Washington Hospital. You combine that with the downward pressure that we've had on reimbursement from government programs since the inception of the ACA, and the problem gets exacerbated. This graph kind of depicts the trend in those shortfalls since 2009. The blue bars being Medicare and the red bars being Medi-Cal. So you see that shortfall increasing in Medicare up through fiscal year 2012 and then declining in 2013 and 2014. But the real story behind that decline has more to do with decreases in volume affecting the shortfall, as well as some strides we've made in cutting the marginal cost for Medicare recipients. But the pressure is still on, and I expect that in the long term trend to continue up in the shortfalls. In fact, the most recent projection I looked at projected that between now and 2024, we could be seeing as much as $10 million less in Medicare reimbursement than we are today. So it's a challenge we're going to have to take on as we get into the future. Medi-Cal, on the other hand, has continued to increase steadily, the shortfall. That increase doesn't get helped by volume either. The more volume in Medi-Cal we see, the greater that disparity gets. Medi-Cal, like Medicare, doesn't cover our costs, so every case we see that doesn't cover cost increases that shortfall. So it's a challenge we've got to take on. Some of this we've talked about. This kind of demonstrates the shift in the payer mix that we've seen in Medi-Cal. But the decrease in private pay, so a lot of those folks that had no insurance did receive Medi-Cal. The decrease in private pay is short of the increase in Medi-Cal. So we've got a shift going on in Medi-Cal, and then true growth in Medi-Cal volume. In 2012, the percentage of gross revenue that came from private pay was 4.6%. the percentage of gross revenue that came from Medi-Cal was 15.6%. In 2015, we're projecting those numbers to be private pay down to 1.4%, but Medi-Cal growing to 19.6% of our gross revenue. So we have true growth in that. Another place we see this is in our ED. This is kind of a graphic illustration of the volume. This is cases seen in the ED. Between 2014 and 2015, we're expecting volume to be up an estimated 2,930 visits in total volume. We have Medi-Cal up an estimated 3,530 visits, being offset by a reduction in private pay visits of about 1,640. So the difference there is true growth in the number of Medi-Cal patients that we're seeing in the ED. And again, as I said, every one of those that doesn't cover costs increases the shortfall of revenue versus expense. Some of the other things that we have facing us in the coming years, Phase 2 construction. This is a great project. This is something that we're very grateful to the voters for allowing us to do for them. But not all of it is going to be covered by the general obligation bond funds that the voters approved for us. Some of it can't be legally. We have total budget of almost $370 million on the new building and the parking garage. However, we have to included in those numbers is equipment, and equipment by law cannot be purchased with general obligation debt. General obligation debt can only be used for the bricks and mortar. So we'll have to come up with about $35 million for that. Likewise, with the construction inflation that we've seen since the voters did approve those bonds, we're going to have to come up with a little bit more money. So in total, the amount of money coming out of Washington Hospital's funds is about $49 million. The good news is the money's there. No problem there. But, you know, the challenge for us is if we want to keep our days cash on hand neutral, we'll need to set aside about $16 million a year to provide for that funding. But again, the money's there, no problem for the project. We'd like to keep the days cash as neutral as we can as we move forward. One of the impacts we're going to have in the future on our P&L is the impact of those buildings and the depreciation and interest that comes with them. These are non-cash issues because the cash flows for the buildings will have already occurred, and the cash flows for the interest is already occurring and will continue to occur. This is really just how we account for those expenses. Depreciation really recognizes those cash flows that are occurring now over the life of the building, and will have to come to the income statement. Likewise, bond interest goes through this accounting convention where while the buildings are under construction, more and more of that gets applied to the cost of the construction, and once construction's complete, we're going to see an increase in the interest expense from where we are now of about $7 million. Again, no impact on cash flow on those things, but from an accounting standpoint, we have to recognize them. The good news is we got 3 years to prepare for this, so we'll be working towards that. And the other big thing we have over the next 6 years is pension funding, and actually longer than 6 years. But this graph really is instructive. It illustrates the growth in the value of the pension assets over the last 14, 15 years, from $70 million in 2001. Now, estimated value of our pension assets is $257.7 million. The board has always taken, and Nancy, has taken the commitment to our employees very seriously with regards to pension. And when our plan got clobbered, frankly, in the financial downturn, like every other defined benefit pension plan out there, you all moved very quickly and increased funding and directed us to increase funding right away. You see that $30 million funding in 2009, and you've directed us to keep that funding elevated until we get this plan back into shape. The good news is it is in good shape. It's considered a healthy plan. Any plan that is funded over 80% is considered healthy. We are well over 80% funding level. But you gave us the directive to not only get that plan above 80% funding level by 2016, but to also be fully funded by 2021, and that will require some elevated contributions to the plan over the next 6 years, and we absolutely intend to do that. A few challenges ahead of us, but I'm pretty confident that these things can be done and done well. In the way we're going to do that, we clearly have to do more with less, right? As the government continues to crank down on our funding, we're going to have to do more with less. We all have heard you got to do more with less, but the question is how? How do you do more with less? We're going to do it with the Toyota production system. This last year, you, the board, and Nancy have approved us to bring this into Washington Hospital. We're going to make it a culture here. Toyota production system, vis-a-vis lean, provides us the tools and the framework to do this. It provides us the mechanisms for identifying waste in our processes, identifying and eliminating waste in our processes. It allows us to promote creativity at every level of the organization in problem solving and create truly elegant solutions to our problems. And it is really how we're going to become a low-cost, high-quality provider, and it will result in higher quality and value for our patients, and after all, that's why we're here. So we're going to move forward with lean, and you'll continue to hear more about that through the years. It's really going to become a culture for us. So that's the environment that our budget was produced in. Sorry about that. This is a real high-level overview of what the budget provides for this year. Total revenue of $477.2 million. And with that, we're going to fund our depreciation expense of $33.2 million. We're going to fund contributions to the retirement plan. Next year, we estimate about $22 million, which is pretty consistent with the elevated levels that you've authorized to move forward with. It's going to provide debt service on our on our revenue bonds. We are expecting operating income of $22.1 million, total net income of $40.5 million after we fold in non-operating income. That includes our property tax revenue of $15.8 million for the debt service on our general obligation bonds. It provides for the funding of our development corporation this year in the amount of $16.8 million. It provides for compliance with all of our bond covenants, and we also includes new capital spending requests of $12 million. This is a real quick look at the income statement. We'll get into the details of this as the night progresses. We're projecting about a 1.5% increase in our net patient service revenue and a 1.7% increase in our total revenue. Operating expenses we're expecting to increase overall at about 3%, with a total bottom line increasing at about 1.7% to the $40,536,000, and consolidated net income of $23.7 million when all is said and done. So we'll get into the details of this, but before we do, I'm going to invite Dan Nardoni to the podium to walk you through some of the assumptions we've made on our volumes that underlie these numbers. So Dan, why don't you come on up?
All right. Well, thank you, Nancy and Chris, for this opportunity to come and present this to you. I, too, want to thank all of management staff for their input into this budget. We wouldn't be here tonight if it wasn't for that and for their hard work. So let's get into the numbers. Looking at our volume indicators, admissions for 2016 of 12,238, increase of about 0.7%. That increase coming from anticipated growth in our neurosurgical product line, along with growth in our medical product lines that we've experienced over 2015. Increases for gynecology, oncology surgeries as these physicians become established in the community, along with small increases in our OB product line related to these mothers who will deliver at Washington Hospital after being seen through the perinatal diagnostic clinic, which we anticipate to open in January of 2016. Patient days of 58,434, going up about 1.5%, related to these additional admissions, which include, again, the neurosurgery, gynecology, oncology surgery, special care nursery, and medical product lines. Outpatient observation days of 3,219, remaining consistent with fiscal year 15 levels. These patients have historically been scattered throughout our med-surg floors, and many of those that come through the ED will be centralized and cared for in our ED observation unit in 2016. Average length of stay of 4.77, going up about 1.3%. This increase is really related to the neurosurgical cases along with the special care nursery days. These product lines historically have longer lengths of stay and are pushing that up. Deliveries of 1,892, up 0.7%. This reflects a small increase related to the opening of that perinatal diagnostic clinic. Historically, these babies could not be delivered here at Washington Hospital. However, as a result of the clinic and special care nursery, which came on board in about 16 months ago, these babies can now be delivered and cared for here at Washington Hospital. We are expecting a lag in these deliveries and expect them to start probably late in the third quarter as the patients start to work their way through the clinic. Surgical cases of 4,296, going up about 1.2%. This increase is related to those gynecology, oncology surgeries I mentioned. And additionally, the joint replacement cases of 1,395 we expect to remain consistent with 2015. Cardiac surgeries of 133 remaining consistent as well. And we expect a 10.4% increase in our neurosurgical cases to 328. Cath lab procedures for 2016 of 5,119, staying fairly consistent with 2015 levels. However, we are expecting some changes in the service mix. Cardiac procedures of 1,774 coming down 5.4%. Peripheral vascular procedures coming up 2.7% to 2,282. Neuroradiology procedures staying consistent with 2015 at 166, and about a 3.6% growth in non-vascular procedures. Emergency room visits of 54,500 remaining consistent with 2015, and our non-emergency outpatient visits of 89,041 with an uptick of about 1%. That 1% is really related directly to the 6 months of activity for the perinatal diagnostic clinic. Moving into our productivity, we're expecting a total productive FTEs of 1,234.5, non-productive FTEs of 183.4 for a total FTE count of 1,417.9. That increase of about 6.5%. The majority of that increase is related to volume and additional open positions budgeted for this year. And it also, 24 of those FTEs actually are the increase due to the programs that Nancy had mentioned, which included the palliative care program, the perinatal diagnostic clinic, the lean promotion office, and the new grad program. All of this is giving us a total paid FTE per AOB of 6.5, about a 4.8% increase over 2015, and a productive FTE per AOB of 5.6, about a 5.7% increase. Okay, moving into our volume trends. Admissions of 12,238. You can see the increase over 2014, and again, that increase for 2016 really relates to those neurosurgery, gynecology, oncology surgery, medical, and OB product lines. Admissions by pair. We take a look at how these admissions stack up amongst our main pairs. You can see that Medicare is remaining fairly consistent and you can see the growth here of PPO from 2014 to 2015. As Chris had mentioned, with the unemployment rate coming down, we expect those levels to be maintained in 2016. You can also see the increase in Medi-Cal from 2014 to 2015 related to the Medi-Cal expansion. And then we expect that growth to continue in 2016. Our HMO, we're expecting to remain fairly consistent. And you can see the decrease in the private admissions from, as Chris mentioned, I think it was about 4% in 2014 down to 1.4% in 2015, and we can expect that to continue in 2016. Inpatient days, following the same trend of the admissions that we spoke of. Deliveries. Actually, you can see the actual growth in deliveries from 2014 to 2015. And a lot of that's due to the strengthening and growth of our OB group with WTMF, the Medical Foundation. In addition to that, in 2016, we've added additional cases related to that perinatal diagnostic clinic. Total surgeries, the trend is pretty steady. And again, that 4,296, the increase there coming from the neurosurgeries and gynecology oncology surgeries. Emergency room visits. This slide kind of tells the story again that Chris had mentioned and Nancy mentioned. That growth from 2014 to 2015, really indicative of the Medi-Cal expansion. And we're expecting those volumes to, in the emergency room, to be maintained in 2016 as well. Outpatient visits, these are non-emergency visits. We had a slight downtick in 2015. The increase you see for 2016 is that 6 months of activity for the perinatal diagnostic clinic. And again, this is only a 6 months of activity. I would expect in fiscal year 17, the full impact of that program, and we'll probably be back up in those 2014 visit totals. With that, I'm going to turn the program back over to Chris to go through the financial information with you.
You know, something that I neglected to note that kind of jumped out in those trends is that volume increase of Medi-Cal in the ED. A lot of that is occurring because these folks that are newly insured can't find a primary care physician that will take additional Medi-Cal because of the reimbursement issues. They simply can't get anyone to see them, so they end up landing in the ED, which unfortunately is the most expensive setting of care for them to end up in. So that is one of the challenges we face with this Medi-Cal expansion is these folks finding someone to treat them. So we're open for them. Getting into the numbers, we'll start with revenue. As I mentioned before, we're expecting about a little more than 0.5% increase in our gross patient service revenue. Contractual allowances increasing about 0.5%. Net patient revenue increasing 1.5% as a result of that at $473,430,000. Our provision for charity care, we do expect to see a little bit more shift from Medi-Cal from private up to Medi-Cal. These numbers really have been based on our last 5 months of experience with private pay, and I think that's indicative of what we'll see next year. So we will see some more shift this year, but not as dramatic as we've seen the last 2 years, I don't anticipate. And as Nancy mentioned, depending on what happens with the subsidies, with the Supreme Court's decision, and if the Supreme Court upholds them, then the expiration of the funding for those subsidies, a lot of that could change. We could end up right back where we were, but we'll wait and see what happens, and we've budgeted assuming that it will continue. So about 2.2% in total net patient service revenue, 2.2% increase when we fold in our bad debt at $431,589,000. This is a quick look at the gross revenue by payer, and again, it kind of demonstrates the shifting we're seeing in our payer mix. You note the decrease in private to the far right there, and the increases in Medi-Cal. And the good news for us is the increases in PPO. We don't expect big shifts in our payer mix to occur from 2015 to 2016. We hope that PPO continues to grow, but it's tough to predict that. It looks like the economy is fairly stable. We do expect to see continued growth in jobs in the district. Tesla continues to grow. Seagate is constructing a new building, and there's a lot of development going around the new BART station in South Fremont. So we hope to see the job market grow and the PPO continue to grow. It's good for our district residents to have jobs in insurance, and it's also good for us. So again, the real shifts occurring in the private and the Medi-Cal and PPO lines, really bringing the percentage of total gross revenue down in Medicare. Other operating revenue, the story here really is the federal meaningful use funds. We did qualify for federal meaningful use funds in fiscal 2014, but because of the way the timing works in the program, we had to wait to get on the next fiscal year cycle before we could claim the next stage of federal meaningful use funds. So that cycle was outside of this fiscal year. We plan to attest towards the end of the year for the federal fiscal year that starts in October. We expect to get about almost $1.4 million in federal meaningful use funds this year. I believe we've pretty much met the requirements already. It's just a matter of attesting and securing those funds. We don't see any other big changes in other operating revenue. Now we'll go through the detail of the expenses. Salaries and wages, expecting to increase about 6%. This has to do with the increases in FTEs that Dan outlined. We do have contractual wage increases included here that range between 1.5% and 3% depending on the unit. And that's really what's driving that increase in wages. Benefits actually decreasing about 2.4%. Increasing 2.4%. That's coming largely, we have some health benefit inflation in here of about 4.5%. We also have an increase in payroll-related taxes. As our salaries and wages go up, we pay more in taxes. We have increase in pension cost, and that increase in pension cost has really got to do with the implementation of new mortality tables this year. We're still waiting to see what the real impact is. We've estimated about $900,000 impact from that. It's been about 10 years since the Actuarial Society has updated its mortality tables, so we're waiting to hear from the actuaries on that, but we're estimating about $900,000 driving that. So that's the increase in pension. Pro fees, pretty flat for the year. We do have some offsets going there. We have some decreases in consulting fees related to our IT projects. Those are offset by increases related to the development of our perinatal diagnostic clinic and an increase from the growth of our interventional radiology program. The volume in that program continues to grow and become more of a dominant force in the cath lab, and there are some professional fees that go along with that. So that's what's driving the increase in pro fees. Supplies really increasing related to volume and inflation. The inflation assumptions this year are 3% overall, with the exception of pharmacy, and Big Pharma somehow manages to find a way to outstrip most other healthcare inflation factors, so we're budgeting an 8% inflation for Big Pharma this year. Purchase services for the year, just a modest increase there. We've got increases for some hardware maintenance. Some of our hardware that was installed with the Epic install is coming out of warranty, and we're going to have to pay for some maintenance contracts on that. That's being offset by a reduction in some consulting projects that we have going, one of them being the Novia project will be winding down this year. Utilities increasing About 8.2%. The big drivers there are electricity and water. We're expecting increases in electricity fees of about 9%. And we've conservatively budgeted water to increase about 50%. As the drought continues in California, the water companies are cranking down on fees. We can't not use water in the hospital, so we're expecting some fairly substantial increases there. Insurance, expected to remain flat. Not a lot going on in the insurance market this year, so we don't expect any real increases there. Marketing and advertising, about $500,000 of increase there. We intend to roll out some marketing campaigns around our relationship with the UCSF this year, and also for the promotion of our world-class joint replacement program. We really need to shout it out. That's a great program, and we also need to let people know about our UC affiliation and all the great things we're doing with it. There's been a lot of good work. Software licenses and maintenance. Continuing to increase. This is related to, this year, related to some increases in our Microsoft licensing fees. We do have the licensing fees for Beaker, which is the new system Nancy mentioned. We're also going to be coming to the board to consider a new decision support system. We installed our decision support system in 1984, so we think it's time to probably take a look at a new one. So there will be some increases in licensing fees related to that. Other expenses, we're expecting an increase of a little over 5%. That's coming from some additional equipment rental, particularly Pyxis. We're going to install some Pyxis machines in the cath lab to kind of keep control of things there. That generally results in some increased revenue, a better charge capture. So we're hoping to gain some of that back in the form of better charge capture. Depreciation expense increasing this year, about $1.8 million. That's coming from, we will be starting to see depreciation in 2016 on the parking garage. That project is expected to wrap up somewhere in the February to April time frame, yeah. We do have the Epic upgrade that's ongoing now. We expect to see about $500,000 of increased depreciation from that. Again, Beaker will be affecting depreciation in 2016. And then we have some new projects and equipment that is normal capital replacement affecting that number. Interest expense coming down $1 million, and again, this is the accounting for the interest as those projects continue to accumulate cost. More and more of the interest gets allocated to the projects. The big ones being the buildings and the parking garage. That will eventually come back. Again, no cash flow related to either one of those items. That's cash flow that's already occurred. Let's see. So, other expenses, not a lot of change there. Provision for bad debt and charity we talked about. Really more of a shift going back up to the Medi-Cal line. And that ends up with total expenses increasing about 3% at $455 million. Quick look at the operating expense distribution. There are some shifts in this year, but it has more to do with, again, the shift of bad debt and charity up to our contractuals line. Bad debt and charity coming down from about 14% of our total expense profile to 9%. That's really causing shifts in all the other numbers related to this, but that's really the impact there. Salaries and benefits continue to make up more than half of our expense profile. So that's that. Quick look at non-operating income. We do expect some increases here. Investment income, we expect to increase about 11.3%, and it's really related to the additional reserves we've been able to accumulate this year. Our bank balances will be higher, so the fees related to that will go up. Rental income net expected to be pretty much the same at $708,000. We do not budget unrealized losses and gains, realized or unrealized losses and gains. What will happen in the market next week, I wish I had that crystal ball. Bond issuance cost for this year, this is going to be a one-time hit of $966,000. This is an amount that the accounting rules used to have us amortize over the life of those bonds, but a couple of years ago they changed the rules and said you have to take the hit when you issue the bonds. So that's driving that number. And our general obligation property tax revenue expected to increase fairly significantly. We will be going out to the market with the second half of the bonds that the district residents authorized for the buildings. That issue will be about $145.5 million. We expect to see that happen in the fall. This is a quick look at the capital projects that we'll be bringing forward to the board to consider in the coming year. We expect total strategic project requests to total about $2.8 million. IT projects totaling a little over $6 million. You know, and IT continues to take up more and more of our capital dollars. It becomes more and more important as we rely on our electronic medical record, and it's just something that we have to do. It's a reality. We'll be coming to the board with equipment requests of $3.1 million. The majority of this is really the stuff that we use up and need to replace on a day-to-day basis. So a lot of things like thermometer stands and blood pressure monitors and a lot of equipment that gets heavily used. As you know, we bring things for replacement when they're really dead, and so that's what we're expecting for this year. So in total, our new request for capital on total projects, about $8.9 million. Like I mentioned, total equipment of a little over $3 million for a total just over $12 million. The ongoing expenditures for projects that have already been approved by the board will be, of course, our Morris Hyman Critical Care Pavilion and our parking garage, $116 million for the building, and about a little under $5 million for the garage. Those two items are funded by our general obligation bond funds. And IT projects that have been ongoing and you have already approved, we expect to spend about $1.7 million to finish those up. And that's the 2016 budget. And at this time, I'd be happy to answer any questions that you might have.
I don't have any.
Sorry, I don't have any questions.
There's one thing I'd like to say before you vote. And that is, you've had a painfully bought financial recovery. And this year we'll have a bottom line. But I think that we have to make certain that this isn't a signal that we go back to business as usual. Medicare is going to continue to strip away reimbursement year by year, step by step. This is not a time where you could believe that somehow we're going to return to the old days. So even though we've orchestrated this financial turnaround, I don't want anyone to think for 1 minute that the clouds have left the horizon. There are some very serious threats to the financial viability of our institution. And this isn't a time where everybody can go back to business as usual. The introduction of the LEAN program is a signal to the organization as a whole that we're never going back there.
On behalf, Jacob, do you have any questions? Okay. On behalf of the board, thank you, Chris, to you and your team. This was a remarkable presentation. You've preempted all of our questions, if we even had any. If Mike Wallace doesn't have any questions at all, then you know you've done a darn good job. So, thank you to
The
everyone.
Mike Wallace test.
Yeah, it's, no, you're the financial wizard.
Yeah, it's a good budget.
Yeah, it is very, very thorough, extremely thorough. So, thank you very much.
Thank you.
All right. I have to check one thing. Okay, we're cool. Yes, we're on to the minutes. So we have consideration of approval of the minutes of May 13th, 18th, 26th, and 27th.
So moved?
Thank you. We have a motion and a second. We have 2 seconds. Bill quietly seconded. All in favor?
Aye.
Would you take a, wait a minute, would you take a roll call, please?
Dr. Danielson?
Aye.
Dr. Wallace?
Aye.
Dr. Stewart?
Aye.
Dr. Nicholson?
Aye.
Dr. Epen?
Aye.
Thank you. Minutes are approved. Do we have any oral communications? No requests? Okay, thank you. We do have written communications from Dr. Lenny.
Okay, I have the medical staff credential action items for May. There are 4 new appointments. The first is Dr. David Chow, internal medicine hospitalist. The second is Dr. Gary Green, emergency medicine. The third is Dr. John Lin, anesthesiology. And the fourth is Dr. Nogo Ravid, pediatric hospitalist. For reappointments, for 2-year reappointments, we have Dr. Jeffrey Carlson, cardiology, Dr. Aruna Chakravorty, endocrinology and internal medicine, who's also going from active to ambulatory status, Gurleen Diol, physician assistant, Dr. Craig Johnson, OBGYN, Dr. Gopala Kolaru, cardiology, Dr. Christina Lee, internal medicine, Dr. Jenny Maltani, neurosurgery, Dr. Deepti Saxena, family medicine, Dr. Rajesh Shingal, urology, Dr. Manish Singhal, internal medicine, Dr. Dennis Townsend, family medicine, ambulatory status, and Dr. Sunil Apender, radiology. For conditional reappointment, we have Dr. Zulfikar Ali, cardiology. We were recommending a 6-month conditional reappointment with professional practice monitoring. Transfers in staff category, Dr. Chakravorty, as mentioned earlier, is going from active to ambulatory status. Completion of proctorship and advancement in staff category, we have Dr. Bern Schmidt, urology, going from provisional to courtesy, and Dr. Philip Young, internal medicine, going from provisional to active. Completion of proctorship prior to eligibility for advancement in staff category, Dr. Akko Walter completed her proctoring. New privilege request, we have Dr. Stacy McDonald from OBGYN requesting a newborn circumcision. And resignations, we have 4 physicians resigning, Dr. Vinod Kurapath, gastroenterology, Dr. Rashmi Patel, internal medicine, Dr. Sweta Singh, pediatrician, and Dr. Huang Trin, family medicine. And those are the credential action items.
Great, thank you. We need a motion, please. to approve.
Second.
Thank you. Christine, would you take a roll call, please?
Dr. Danielson?
Aye.
Dr. Wallace?
Aye.
Dr. Stewart?
Aye.
Dr. Nicholson?
Aye.
Dr. Epen?
Thank you. Motion passes. Thank you. Debbie,
Hi.
please tell us about the service league.
Hi, we're doing well. Just wanted to kind of update you on what's been happening the last month. Last month, we actually had our interviews for our scholarship recipients. We had only 7 applicants this year. We were kind of surprised. Last year, we had 16 applicants. Obviously, the applicants were, I think we have a really unique situation. A lot of scholarships are done all by paper, but we do interviews, and I think that really puts a personal touch. You really get to know the candidates, and it's amazing. It's not just about the paperwork and the grade point averages and everything. It's about the overall person. And the committee was the people that were on the committee was Vida Reed, Angus Cochran, our first and second vice president, Jose Aguirre, and Pooja Mahan, and Diane Zarzinski was our chairman. And the committee has selected these 4 applicants to receive the Josephine Walton Scholarship was to Niall Amida. Kathleen Fusco Scholarship went to Michael Nung. Anna Aola Scholarship went to Parveez Patel. And by the way, that particular scholarship is only awarded to a current volunteer at Washington Hospital for the Anna. And the last one was a Jerry Claire Jamoral Scholarship. This is a one-time scholarship, and this went to Lynn Thoreau. And all the candidates were quite excited about it. And we're pleased with the selection. I was just a silent partner on the committee, but it was a very interesting process. Now, all of these candidates, when they apply for scholarships for us, for the Service League, are going into the medical field. So I think that's very, very important. Looking forward to seeing maybe even some back here to take care of us. Okay, and then on May 19th, we had our orientation, and because orientation and information sessions are being not quite as frequently as they have in the past, but we did have 23 new volunteers, 2 spiritual care, 1 adult, which we hope will get more adults because we really would like to see more adult volunteers here at the hospital, 10 college and 10 high school. And then our last thing is that we are starting tomorrow morning, I will be there, a new pilot program in the medical imaging and interventional radiology department. And we have 2 volunteers that are going to do this on Thursday, 1 in the morning session, 1 in the afternoon session. Sydney will do the morning, and Cherie will do the afternoon, and I will be backup. And what we're going to do is help make it a little bit easier there to help make sure our patients are getting the care that they need when they come in to have these procedures. And make sure that they get to the transition back into the radiology and get taken care of, as well as their families, to make sure that they are everything's addressed for them. So, and I know this is a very important program, like all programs here at the hospital, but I'm really excited about being a part of that and making this work and having that consistency of the volunteers. Now, this only occurs on Thursdays, but depending on how things go with the program, we'll expand it if they do more scheduling of these appointments during the week. So that pretty much covers it for us. And this is a 2-month pilot program to see how it all works out. So.
Thank you, Sherry. I have to tag on just a little bit to your report.
Yes.
Our Optimist Club gave out some scholarships as well.
Yes.
And I didn't know who the winners were going to be, but I found out that several of our young people that were chosen were volunteers here at the hospital. And I was greatly surprised and impressed at the same time. And I think a couple of them, we awarded scholarships to them as well.
Oh,
so,
great.
We both are like minds.
Yes.
And they were very, very exciting young people that you just know you feel good about the future.
I have to agree. I have to agree. We hear so many things on TV and stuff, but to see these kids and how hard they work and how dedicated they are and their passion, the passion that they have to go into the medical field is reassuring.
And the support of the parents as well.
Yes, and that takes a lot of support.
It was good all around.
Yes.
All around.
So,
okay.
Thank you for sharing that.
Okay. And don't forget about the jewelry sale.
Okay.
Later on in the year.
I promise.
Thank you, Debbie.
You're welcome.
Dr. Lunny, would you please bring us back to sensibility and tell us about a medical staff report?
Okay. Our medical staff held its awards dinner on May 30th, where Dr. Akaweli, our Director of Critical Care, was honored. In addition, the Nurse of the Year awards for 2014 and 2015 were bestowed. And then we acknowledge the dedication of medical staff members who volunteered their time in service to be department chairs and medical staff leaders. Our current medical staff is 545 members strong. There are 338 active staff members, 62 ambulatory, 26 courtesy, 15 allied health, 98 provisional, 3 consulting, and 3 administrative. And we currently have 25 applications in process, 17 of which are formal applications, and 8 are in the pre-application stage. So,
You're busy.
yep, definitely busy.
That number just keeps growing and growing. It's good to see. Thank you. Thank you.
I'd like to ask the board to join me in thanking Dr. Lunny for his 2-year stint as our Chief of Staff. This will be his last board meeting.
Oh, that's true.
It's been a pleasure, and I've enjoyed working with the board and administration
We'll
the last
miss
2
you.
years, and I will be ably replaced by Dr. Achanta in July.
Thank you for your service. Nancy, I believe we're ready for the hospital calendar.
Okay, we'll go to the video first.
Past health promotions and outreach events. On Thursday, May 14th, the Washington Hospital Green Team hosted an Energizer station as part of the National Bike to Work Day. At the Energizer station, cyclists were treated to coffee, pastries, fresh fruit, along with a Green Team Bike to Work Day messenger bag and a Green Team reusable coffee mug. 12 cyclists participated. On Thursday, May 14th, Washington Hospital hosted Celebration of Life. This event featured stories of survival and hope for cancer survivors and their families. Dr. Vandana Sharma, oncologist, provided the welcome address, and Dr. Victoria Leapart, gynecologist, moderated the event. The event is sponsored by Washington Hospital, HERS Breast Cancer Foundation, Palo Alto Medical Foundation, and the American Cancer Society. 90 people attended. On Thursday, May 28th, Michelle Heading, RN, Spiritual Care Coordinator, presented Grief and Beyond to the staff of the Fremont Family Resource Center. The workshop provided helpful tips for social service and healthcare providers on how to recognize signs indicating that a grieving person may need professional help. 13 people attended. On Tuesday, June 2nd, Dr. Dale Amanda Tyler, otolaryngologist, head and neck surgeon, presented The Real Impact of Hearing Loss and the Latest Options for Treatment. 53 people attended. On Thursday, June 4th, as part of the Diabetes Matters series, Dr. Prasad Kata, endocrinologist, presented Diabetes Ups and Downs, Troubleshooting High and Low Blood Sugar Levels. 12 people attended. On Friday, June 5th, Washington Hospital participated in the Four Seasons of Health Expo organized by the Tri-City Elder Coalition. This event featured 116 vendors providing information for seniors. Washington Hospital provided osteoporosis screenings and information on health insurance options. 74 bone density screenings were provided, and over 2,000 people attended the event. On Saturday, June 6th, Dr. Ash Jain, cardiologist, and Dr. John Thomas Mahegan, vascular surgeon, screened community members for peripheral vascular disease. This free screening included a Doppler study of the circulation in the legs and an interpretation of results. A total of 101 people were screened. Of the 101, 14 were found to have possible atrial disease and 13 were found to have other vascular issues requiring follow-up. Upcoming health promotions and community outreach events. On Tuesday, July 7th, from 6 to 8 p.m., as part of the Stroke Education Series, Dr. Ash Jain, cardiologist, Doug Van Houten, RN, and Luann Sadweste, RN, will present Introduction Stroke and Risk Factors for Stroke. The 2015 Central Park Summer Concert Series kicks off on Thursday, July 9th. Washington Hospital is a co-presenting sponsor. This 6-week concert series is free and open to the public and will be held at the Central Park Performance Pavilion on Thursdays from 6 to 8 p.m. Washington Hospital will be providing health information and health screenings during this 6-week concert series. The Washington Hospital Healthcare Foundation Report. In late May, the Washington Hospital Healthcare Foundation Golf Tournament Committee met to review the success of the tournament. The 30th annual golf tournament was held on April 27th in memory of longtime Fremont businessman Jean Angelo Pisano. Tournament chair Lamar Hinton reported feedback received by the committee was very positive and that the golfers enjoyed the outstanding day of golf at Castlewood Country Club. Lamar expressed, "I am proud to say we hosted a terrific tournament for approximately 200 golfers. Thanks to all our generous sponsors, volunteers, and golfers, we raised over $82,000 for surgical services at Washington Hospital." Next year's golf tournament will take place at Castlewood Country Club on April 25th, 2016. The Washington Township Healthcare District Board of Directors Report. Washington Township Healthcare District Board members attended the annual fundraising dinner for One Child on May 29th and the Celebrating Business Luncheon hosted by the Newark Chamber of Commerce on June 10th. Washington on Wheels WOW Mobile Health Clinic. During the month of May, the Washington on Wheels Mobile Health Clinic WOW continued to serve community members at the Fremont Family Resource Center, the Fremont Senior Center, the Ruggieri Senior Center in Union City, and Breyer Elementary School in Fremont. In addition, Washington on Wheels conducted hearing and vision screenings for students of the Fremont Unified School District State Preschool Program. The total number of community members receiving health care at the Washington on Wheels Clinic during the month of May was 167. Internet marketing. Washington Hospital's website remains very active. The hospital's Physician Finder section was May's most viewed webpage with 13,484 views. InHealth, Channel 78. During the month of May, Washington Hospital's cable channel 78 InHealth captured new programming, including a health and wellness program entitled Treatments for Knee Pain and a Diabetes Matters program called What Do All Those Labs Mean? Understanding and Using Your Results to Improve Diabetes Management. In addition, InHealth aired a new health and wellness program titled Minimally Invasive Gynecologic Surgery, the April Citizens Bond Oversight Committee meeting, and the May Board of Directors meeting. Additional events. On May 30th, the Washington Hospital medical staff hosted a recognition event. The event honored Dr. Peter Lunny, nephrologist, for his leadership as Chief of Staff for the past 2 years, and welcomed incoming Chief of Staff Dr. Karanthi Achanta, surgeon. The event also recognized Dr. Carmen Akawili with the 2015 Remo Cerruti MD Physician of the Year Award. For more information on any of the programs mentioned, visit whhs.com or call 1-800-963-7070, and please follow us on Facebook and Twitter.
Before we get to the Employee of the Month, I wanted to talk to the board about Local 20. We've been in negotiations with them. Their membership have ratified the proposed contract, and it hit my desk this morning. In no way, shape, or form does this meet the criteria of an emergency item added to the board's agenda, but I was hopeful that if I could discuss with you what the terms of the contract are, that with your permission I could put it on the Monday night board meeting's agenda for board consideration. We'd like to move it along, and with them having ratified it, I thought it would be a good idea to share that with the Board of Directors. The term of the Memorandum of Understanding would run from February 1st, 2015 through January 31st of 2018. There are no reopeners. This membership agreement would cover 118 employees as of June 10th of this year. It includes pharmacists, laboratory, and the rehab employees that we agreed the union could accrete. That includes OT, PT, and speech. For the therapy group from rehab, they were below market levels, so we had to move them up or risk losing them. And the board's policy is to meet the market. So with their group, there's a slightly more generous arrangement in pay, and it goes like this. Upon board approval, 2% across the board increase. On August 1st of 2015, another 2% across the board increase. On February 1st, 2016, a 2% across the board increase. In August of 2016, a 1.5%. And in February of 2017, a 2%. For the non-therapy group, which is the pharmacists and the laboratory employees, upon board approval, it would be 2% across the board increase. In August of 2015, a 1% lump sum payment. On August 1st of 2016, 2% across the board. And August 1st, 2017, 2% across the board. We believe that this meets the market and is consistent with the board's stated policy. So with that, I would like to recommend to the board that we put this on the agenda for Monday. Okay. The second thing I wanted to talk to you about was we've had a flurry of activity related to organ donation and tissue donation, and I thought it was important to share it with the community and the board. Through an organ donation patient at Washington Hospital in March, we had a 29-year-old and a 66-year-old man receive organ donation. One recipient successfully received a kidney and a heart transplant. The other successfully received a kidney and a liver transplant. In April of this year, we also had a patient at Washington Hospital who saved the lives of a 67-year-old man, a 57-year-old man, and a 45-year-old woman. 2 organ recipients received a successful kidney transplant, and 1 successfully received a liver transplant. It's a very personal decision for families and patients. And the role of the partnership between Washington Hospital and the donor network is to provide education and resources so patients and their loved ones can make well-informed decisions, and we're very pleased that we were able to do that 2 months in a row, and very happy for the people receiving organs and deeply grateful to the families donating. I'd like to go to our Employee of the Month. We're up. Do you have her photo? Oh, there she is. Okay. This is Nicole Leva. She's a surgical support technician in the operating room and perioperative services. She's our June Employee of the Month. She's been with the operating room and perioperative services department since March of 2002. Prior to that, she was in materials management as a central supply tech, and before that in food and nutritional services as a general dietary aide, where she worked per diem for 4 years. And she says the OR is like a family. We work as a team, which makes what we do every day very rewarding. I'm lucky to have a job where I make a difference in people's lives, and that simply makes the OR team that much more cohesive. Her supervisor and colleagues obviously feel she's an outstanding Washington Hospital employee who earned this recognition because of her outstanding work and commitment. Nicole's job requires that she interact with patients and caregivers all day long. Perioperative Services Manager Suzanne France says her positive attitude and caring nature definitely adds to our patients' positive experience. She's also incredibly dependable, which is why her colleagues go to her when they need support. She is a wife and a mother of 3, and in addition to her home and work life, she's also enrolled in a surgical technician training program, and she hopes to earn her certificate this year. When we walked into the surgical lounge to make this award, she wasn't there yet, but the doctors that were in the lounge let all of us know what a good choice this was. They were very proud.
Thank you. One of my favorite items on the agenda is the construction report with Ed Fay.
We're still digging.
We're still digging?
Yeah.
Okay.
No.
We won't go that far.
Okay, so for this month, most of the activity that we have to report is actually on the garage. So this report is showing you the schedule and showing you that so far we're running on schedule with the garage. The work that's been done out there this past month is basically getting the first floor poured, about 50% of it poured. So you can see here, laying of the rebar, the pour starting, and this is on the far end of the garage, the end farthest away from the hospital. And you can see that's the completion of the pour. This is not the entire first floor slab. It's going to be done in 2 phases. And the next phase is going to be done, this shows you the area that wasn't poured. And this is the area that will be poured this coming week. This is also a good picture because it shows you the beginning of getting ready for the next step, which is you can see the red. See if I figure this out. Okay. You can see well, they don't look so red in this picture, but they are a red mold or cast. And these are for the beams for the next floor. And so these are being set up in place, and these will be poured after the first floors, after the rest of the concrete here, and then we will start to see the buildup of the second floor. In response to questions about how is this going to work now, this is going to go up floor by floor. So as you might remember, there are 7 floors. So basically every month that I come in for a report, we should see a new floor being either up already or going up. And so you'll see these kind of molds going up first. Well, you'll see this being poured, you'll see these molds going up, and then you'll see the molds poured, and then the floors being poured in sequence. Probably combination, it'll be about 3 or 4 pours per month of new concrete. And then also you can see after these floors are in place, then the columns will be built up to the next floor, so in preparation for the ensuing buildup. So that's what you can anticipate so far. Things are going well, and we're going on time and on schedule. Any questions as far as the garage goes? We're still working towards the March 9th date. I'm told by our contractors that all of the concrete will be poured and all the floors in place by Christmas. So 1 a month, we've got 7 total. This is showing you the excavation, and there's a lot of work going on, but you're not going to see as big a difference from the previous month. This shows you the main footprint. As of today, again, it's very light on this screen, hard to differentiate, but there you can see barely make out lines. Each line is a lift. They're into the 6th lift today. And so that'll be the end, and then we'll start to see the ground being sort of leveled out, and then you'll start seeing piers being drilled in for the support that will then have the base isolation sitting on top of that. So this is pretty much the same thing that you've seen before. lagging being put in place for tiebacks. They put shotcrete along the sides as they go down. And we continue to have a lot of dirt taken out of our premises. Okay, any questions?
Looks good. On time, on budget, right?
Still, yes. Thank you.
Okay, thank you. We're now ready for our quality report from Barry Bowen.
Good evening, thank you. Tonight I wanted to share our most recent quality dashboard for quarter ending 3/15 in quality. I wanted to start off with reviewing a couple of our core measures. The first one being venous thromboembolism prevention. This is basically a core measure that we're required to look at that's situated around preventing patients from developing clots while they're at the hospital. And we look at it in the med-surg setting and in a critical care setting. And you can see that we've, in the last quarter, we had met the benchmark for state. We're just about 1% below for the national average at 89%. And in ICU, 100% compliance there with preventing VTE. And also, with these patients typically can be discharged on blood thinners, and it's important to give them the right instructions to monitor their compliance with that at home, and so that they're educated on signs and symptoms to watch for when you're taking a blood thinner. So 100% of the patient population received education on their medication management. And moving into stroke, again, this looks at all patients who come through who are diagnosed with a stroke. We also have to do some discharge medications to prevent further blood clots from developing. That was met with 100% compliance. These patients require a very standardized education format when they leave, and CMS has very specific criteria on how that education should be done. We met 100% compliance with that. And patients typically require some form of rehab at discharge. So we document the appropriate rehab and how we did education for that. We were at about 99% compliance for that last quarter. So those core measures look good. Moving into our infection prevention indicators, central line associated bloodstream infections. Again, this is the medical device that's implanted so patients can get their IV fluids through a central vessel. We did have an elevation in central line associated bloodstream infections. These were 1 in critical care and about 4 in the med-surg settings. Puts us at about 1.2. It's a little higher than what the CDC would expect us to have. We're looking into doing re-education around a standardized prevention bundle, which is basically you look to make sure that every patient who has a central line in place has a medical necessity for that. We review that every day. That's actually state law in California that those patients are reviewed, that we are changing our dressings appropriately, we're using proper hand hygiene. All of these things combined together tend to prevent CLABSI. So we're going to go back and do some education on that. Each one of these cases did have a root cause analysis, which kind of gives us some more information on what we think the potential cause may be. Moving into surgical site infections, we only had 2. That was out of a little over 900 procedures that were surveyed. Again, in California, they have strict criteria on the number of procedures you survey. We look at about 27 types of surgical procedures, and again, we only had 2 surgical site infections. That's below the benchmark, less than the CDC would expect us to have. Moving into C. difficile, this has been a challenge for us. It's something we've been working on for over the last year on really looking at an initiative to bring this down. We've had some success. This last quarter we did go up. We had about 5 more C. diff infections, and we've done some root cause analysis on that also. And we think that part of it was we did have an influx of patients, as you're aware of. In the first quarter, our census was fairly high, running around the estimated about 183 patients, average daily census, which means that at some periods we were even over 200 patients. That leads to more visitors, more people being in the building, and anytime you have a population of people that come together in a space and that increases, you run the risk of infection spreading. So we are again focusing on continuing to clean appropriately, hand hygiene initiative, and monitoring our antibiotic use, and hoping that that should come down in the next quarter. Catheter-associated urinary tract infections, we did have a slight increase in that. We had 7 of those, again, throughout med-surg and critical care setting. Put us at 1.3. It's slightly higher than what the CDC would expect to have. There's some things that we really want to focus on, again, related to education to prevent this. It goes back, again, to looking at how long do the catheters really need to be in place? Do they have a medical necessity to be in place? We're getting together a task force, and we're going to be looking at implementing some protocols to make sure that we look at those catheters every single day. And if they don't need to be in there and there's not a documented medical necessity, looking at developing protocols that will get that catheter out as soon as possible. If the device is out of the patient, you no longer have the risk. So we want to make sure we're doing the appropriate action there. Hospital-acquired MRSA, again, that's that bacteria that's very difficult to treat with antibiotics. We did have 1 hospital-associated MRSA, and that's all it takes to put you above the benchmark. You can see it's slightly higher than what they expected. This particular patient actually had a prior history of what we call colonized infection, meaning that when they arrived at the hospital, we swabbed their nose, and they did turn out positive, meaning they didn't have an active infection going on when they walked in, but we did know that they were colonized with this bacteria. It moved into an active infection while they were here, which this was a pretty sick patient. But the CMS, the Centers for Medicaid Services, is very clear that even if it happens under those circumstances, you have to count it as a hospital-associated infection. Same thing with this case of hospital-associated VRE infection. Patient had a prior history. Unfortunately, they were sick enough to where it sort of progressed and came out again in their blood. So we do have 1 hospital VRE. Moving into our nursing sensitive indicators, looking at patients who develop a pressure ulcer while they're here, we did have 2, it's slightly above the CalNOC benchmark. And moderate falls, moderate injuries with falls, did have 1 fall that resulted in an injury. This puts us at about equal where the benchmark is. It's actually a decrease from the quarter before. And we concentrate on our Joint Commission National Patient Safety Goals. Data here looks good with the handoff. Communication is happening about 99.7% of the time. Basically, this has been good for the last couple of years, that we're really assuring that the communication that needs to happen face-to-face in between shift is occurring here, which reduces your risk for having breakdown in communication leading to patient errors. Same thing with patient identification, 100% when done through direct observation. 100% of patients who needed to be ID'd properly word that we followed all the process and procedures there. Also applies to procedured timeout, making sure that before an invasive procedure, everybody in the room stops, goes over the right patient, the right type of procedure. It's occurring 100% of the time on direct observation audits. Hand hygiene, we've continued to have some success there. We're above the Joint Commission recommended benchmark of 90%, at 97.5%. This is a real success considering the type of volume we were experiencing in this quarter. And we have a lot of surveyors out there making sure that this happens, that people are performing their hand hygiene. We change our surveyors, we retrain according to Joint Commission guidelines. So I feel confident that this data is good with our hand hygiene. Looking at our readmission rates, this is again based on Centers for Medicare and Medicaid Services, looking at how many patients come into the hospital with pneumonia and then we see them back in 30 days. This was about 14 patients last quarter. It's a 15.5% patients that were readmitted within 30 days. The national average from CMS is 17.3. So that's over the 3 months, it averages out to be a little bit better than the benchmark. Heart failure patients, another population we look closely at, monitor for readmission. In the past quarter, we had a rate of 22.6% of the patients that were discharged were readmitted within 30 days. This is just ever so slightly better than the CMS national rate of 22.7. Of these patients that came back, half of them were readmitted related to their CHF diagnosis. The other half had something removed from CHF. But again, they're going to look at all cause. It doesn't matter what the patient comes back in for, since about 50% were not related to their CHF. AMI did well with that at 6.3% of patients who had an AMI, otherwise known as a heart attack, were readmitted within 30 days. This is better than the CMS national rate of 17.8. In fact, it was only one patient that came back, and that patient just had a little bit of a dysrhythmia, so they went ahead and admitted that patient to monitor them. And those are our quality indicators for quarter ending 3/15. If you have any questions. Thank you.
Thank you. Thank you. We have our regular monthly finance report from Chris Henry. We have to distinguish it from the budget.
And tonight we'll be going through Washington Hospital's operating and financial results for April 2015. April's continued our strong performance this year. Let's take a quick look at our operating indicators. Average daily census for April was 9.8 above budget at 157.6. All of our operating indicators really stronger than we expected. Generally, we start to see things tailing down in April, but this spring things are just moving right through. Admissions were 65 above budget at 985. We had 4,728 patient days, 295 above the budget of 4,433. Our outpatient observational equivalent days were 80 above budget at 283, and our average length of stay was very close to budget at 4.86. We had budgeted for 4.82. Case mix in the index for the month was really quite high at 1.569. We had 27 more deliveries than we had expected at 157. Our surgical cases came in 21 above budget at 391. We had 137 joint replacement cases. We'd expected 121. Neurosurgical cases were 8 above budget at 29, and that's a lot of the driver on that case mix index number. Those are high acuity cases typically. Likewise, our cardiac surgical cases were 2 above budget at 11, and again, those are high acuity cases. Cath lab procedures for the month were 38 above budget at 651. Our outpatient visits were 110 below budget at 7,565. And our emergency room continued in their high levels of operation, 490 visits higher than we expected at 4,468. Quick look at our cath lab activity. Pretty much even between peripheral vascular and cardiac this month. Non-vascular interventional radiology procedures came up at 18%, and our neurointerventional radiology cases were 6% of the volume for April. Quick look at productivity. Productive FTEs were 52.6 above budget at 1,176.7. With all that activity, we needed more folks in the house. Non-productive activities for April came in at 159.3, giving us total FTEs 51.8 above budget at 1,336. However, our FTEs per AOB, which is our productivity measure, came in 6.26, below the budget of 6.48. So again, management did a good job of staffing and controlling the staffing given the high levels of activity. So let's take a look at the numbers. First, we'll look at our Governmental Accounting Standards Board presentation. This is a representation of the way we produce our audited financials. Total patient revenue came in 9.7% above budget at $178,706,000. Our contractuals for the month came in at 77.2% against a budget of 76.32. And again, that's reflective of the shift in Medi-Cal that we've seen all year from private. We ended up with net operating revenue for April $2 million above the budget at $40,986,000. Operating expenses for the month were 5.4% below budget at $36,996,000. We saw that largely driven in the areas of of our salaries and wages actually were above budget, but that was offset by our benefits expenses, which were significantly below budget by about 18%. We really had a lot lower health and welfare claims during the month. And again, our lower provision for bad debt and charity, about $2 million below budget. Again, that's more of a shift up to the contractuals line, but again, we're seeing some growth in that as well. So we ended the month with an operating bottom line of about $3.990 million, almost $4 million. We really had expected to break even in April in the budget. And just for comparative purposes, year to date we're running at with an operating bottom line of about $22 million. Last year at this time we were looking at a $14.5 million loss. So really a significant turnaround happening this year. Non-operating income for April came in at $926,000, a little bit below the budget of $1,092,000. We did have a $90,000 unrealized loss in our investments this month. That number's kind of been rattling around a fairly narrow range this year. So we ended April with a total bottom line from a GASB perspective at about $4.9 million. We'd expected about $915,000, so a lot better performance in April than we saw last year. Take a quick look at our Financial Accounting Standards Board presentation. This is a representation of how the financial markets might look at these numbers. Our operating bottom line remains the same at almost $4 million. We pull out our property tax revenue that supports our general obligation bond debt service and that unrealized loss on our investments to come up with non-operating income from a FASB perspective, about $76,000 below budget at $232,000, and a total bottom line a little above $4.2 million from a FASB perspective. So are there any questions on April?
Go ahead.
Okay. I'm sorry.
These are the preliminary results for May. We saw 997 patient admissions. That resulted in an average daily census of 162.7. That was 35 patient admissions higher than the budget. The average daily census was about 14.3 days above budget. Average daily census recorded in May was 5.4% higher. The high and low range from 173 down to 133. Outpatient observation equivalent days of 280 were higher than the budget of 205 and higher than in May a year ago. The average length of stay based on discharges for adults and children was 4.68, which was lower than we had budgeted at 4.78. It was also lower than the preceding months. The birthing center saw 137 deliveries in May. We thought we might have 151. The deliveries resulted in 284 baby days of care. The newborns totaled 140 this month. By comparison, a year ago we had 159 deliveries. In surgery, we saw 371 surgical cases, an 8.5% positive variance, or 29 more cases than we had budgeted. The surgical activity included cardiac surgery cases that came in below budget by 2 cases. The neurosurgical cases were 5 cases below budget. The joint replacement cases were 11 cases above budget for a total of 116 cases, or a 10.5% positive variance. General surgery cases were also above budget by 25, or a 12.5% positive variance. Inpatient surgical cases were above budget by 15, while outpatient surgeries were above budget by 14. So in both categories, we had greater than expected activity. 575 cases were seen at the outpatient surgery center. We had budgeted for 533. For the month of May, the total procedures in the cath lab were 564. We had budgeted for 605, so the cath lab was not as busy as we had planned. The overall cath lab volume for May a year ago was 563 procedures, so that's about dead even with a year ago. Overall, cath lab procedures for inpatients were 25 more than anticipated, and the outpatient procedures were 66 fewer than expected, for a negative variance of 21.8% for outpatient procedures. The May's cath lab activity included cardiac procedures that were 18 below budget, peripheral vascular procedures that were 4 cases below budget, neurointerventional radiology procedures that were 7 cases below budget, and non-vascular interventional radiology procedures that were 7 lower than the budget. Non-emergency outpatient visits. We had a total of 7,221, 203 lower than the budget and lower than May a year ago. The emergency room recorded a total of 4,602 patient visits in May, 177 cases more than we had budgeted. The daily average for the month was 148 visits, so you can see that the emergency room volume is considerable. May's visits totaled 151 more emergency room visits than May a year ago. The Washington, Warm Springs, Newark, Nakamura, and Ohlone clinics saw approximately 3,958 patient visits during May, which was 37 fewer than the budget. The total system emergency room and clinic visits for May came in at 8,560 compared to a budget of 8,420. In terms of personnel, the full-time equivalents for the month of May totaled 1,350.7, and of that number, 20.5 were agency personnel. This was higher than what we had budgeted, and I think it directly correlates with activity. The productive FTEs were above budget by 73.5 for the month. Non-productive FTEs came in at 15.4 above budget. Our productive FTEs per adjusted occupied bed were 5.44 in May, which was a 4.4% variance below the budget, which had called for 5.69. Total FTEs per adjusted occupied bed came in at 6.11, which was 3.9% below the budget of 6.36. So again, careful control. Our preliminary information on patient mix indicates that inpatient revenue for the month of May amounted to approximately $125.9 million, compared to a budget estimate of $122.2 million. Of this amount, 59.1% came from Medicare-sponsored patients, and we had budgeted 57.6%, so more Medicare than we had anticipated. 14.6% came from Medi-Cal-sponsored patients. The budget had called for 16.8%, so on the other side, it was less. So total government program revenue for May was 73.7% of total inpatient revenue. The budget had called for 74.4%. We came in under that, which is good. Based on May's 5,044 patient days, 57.2% were Medicare-sponsored days, 16.7% were Medi-Cal-sponsored days. Total government program patient days for May were 73.9% of total inpatient days versus a budget of 75.5%, so we came in under that. Preliminary information indicates that total patient revenue for May was $171 million, and this was above the budget by approximately $7.5 million, or 4.6%. 1% positive variance. It included inpatient revenue that was above budget by $3.7 million and outpatient revenue that was above budget by about $3.8 million. The inpatient revenue variance was driven by higher levels of activity in the operating room and the cath lab and the associated ancillary services. The outpatient revenue was higher than budget primarily due to the increased outpatient activity in the OR and the emergency room. So in summary, in May, our inpatient activity included 35 more admissions and 444 more inpatient days than we had planned. Surgical cases came in above budget by 29. Cath lab procedures came in below budget by 41. Outpatient visits were 2.7% below budget. Emergency room visits were 4% higher than anticipated. Clinic visits for the month came in 0.9% under the budget. Our total FTEs were above budget by 7%. FTEs per adjusted occupied bed were below budget by 3.9%. Our total hospital charges for May were above budget by approximately $7.5 million. On May 31st, there were 195 days cash on hand, up from April, which was 189. The total days revenue and accounts receivable at May 31st was 58.1. The days revenue and accounts receivable excluding Medi-Cal was 55.4. During the month of May, $887,037 of charges were approved or are pending for charity assistance.
That completes our finance report and our hospital operations report, and we do have a number of action items on our agenda this evening. So, I'm ready.
Madam President, I move for the adoption of resolution number 1154, which is the budget estimate for fiscal year 2015-2016. This resolution provides for the necessary funds required for the operation of the district and for the continued support of the Washington Township Hospital Development Corporation in its operations to provide the charitable and community services mission of the district.
Second.
We have a motion and a second. Do we need any further discussion?
No.
Okay.
Good budget.
It is a good budget. Christine, would you please take roll call?
Dr. Danielson?
Aye.
Dr. Wallace?
Aye.
Dr. Stewart?
Aye.
Dr. Nicholson?
Aye.
Dr. Epen?
Aye.
Thank you. Motion passes. Chris, you have your budget. Next item.
Madam President, I move for the adoption of resolution number 1155, which formally establishes the Washington Township Healthcare District Retirement Plan Funding Policy. This policy establishes standard for the funding of the retirement plan's pension obligations by the district.
Second.
Do you have it up? Okay, we have a slide we want you to look at.
All right, great.
Actually, I want to bring up the slide I showed you a little earlier on the pension plan. It has always been the policy of this board to keep the pension plan funded, and this board and our CEO's commitment, as I said earlier, to this is firm, and it's exemplified in the numbers you see right here. The resolution that you're considering now is really a memorializing of the stance that the board has already taken on this. It was, I think rightly, in the past, a formal policy on this was not required. But I think rightly, the Governmental Accounting Standards Board is now requiring a formal policy on this. It is what you've already been doing and what you've done for years and years and years. That's really pretty much it. It's memorializing what you've already done.
I think it's especially commendable that our board has gone to such lengths to secure the retirement of its employees when so many of the public agencies have not been able to do that. CalPERS has their pension funded at 47%. And you have kept faith with the employees year after year, and you have made sure that nothing like this could happen to them. And I think that it's a distinguishing characteristic of our district that our board has done that. And all of the employees owe you a debt of gratitude.
Chris?
Yes.
Do you expect this to get us fully funded by 2021, is that correct?
That is the directive you have given us.
That's what we want. That's what we want. And
we will do our darndest to fulfill that directive. You're
with
darn right.
reasonable actuarial assumptions, are we going to have to make much deviation from the amount of contributions that we've made in the last several years?
We may.
Somewhere around 20 million a year?
Yeah, I would say upwards of 20 million a year for the next 6 years.
Mm-hmm.
Again, a lot is kind of pending on the implementation of the new actuarial mortality tables.
Right, okay.
We'll have a better handle on that before the end of the month, I'm hoping.
That's going to come out this month?
Yeah, we expect to get some preliminary numbers early or later this month.
Okay,
So
yeah.
when we do get those, I'll be sure and report them back to you. But I would estimate back of the napkin, we're going to be somewhere in the 22 to 25 million dollar a year funding level for the next 6 years.
Be a real accomplishment when we get there.
You bet.
And stay there.
You bet. Yeah.
Good.
But we're looking good so far.
Mm-hmm.
Any other comments? Christine, would you please take roll call?
Director Danielson?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Eekman?
Aye.
Motion passes. Thank you. Item C.
Madam President, I move for adoption of the revised statement of investment policy of the district as recommended by the district's investment advisor and reviewed by the board of directors.
Second.
Do we have any further discussion?
And what I wanted to point out simply is that the investment policy that we use is dictated by state and government codes and local district law, and the revisions are necessitated by the need to bring the policy in compliance with changes in these standards, and they are externally imposed.
Okay, great.
You don't really have a lot of choice.
Okay. Make sure we're compliant. Christine, would you please take roll call?
Director Danielson?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Eekman?
Aye.
Motion passes. Item D.
Madam President, in accordance with the district law policies and procedures, I move the Chief Executive Officer be authorized to enter into the necessary contracts and proceed with the purchase of the hardware, software, and implementations services of the supply chain management fiscal management system upgrade for a total amount not to exceed $329,335. This is an approved project in the 2015 capital budget.
Second.
Motion is second. Nancy, do you have anything to elaborate on that?
Yes, I would like to explain a little bit about it. These are the computer systems that are used for purchasing, materials, inventory, accounts payable, our general ledger, project accounting, fixed assets, and budget tracking. This is a system that is owned by McKesson, in the sense that they sold it to us. During this year, this calendar year, they will end support for the versions that are installed at our hospital, and Microsoft, which has a piece of it as well, will end support for both the server and the PC operating systems used to run the applications. So we're asking for an upgrade that will enable us to migrate to the high availability virtual server environment, to improve monitoring and analysis with more robust enterprise resource planning and a solution report writer. It will also allow us to better support the activities we're involved with lean and cost-saving initiatives relating to supply chain management and inventory control. It will take 7 months to complete the project.
Thank you. Any further questions or comments? Would you take roll call, please?
Director Danielson?
Aye.
Director Nicholson?
Aye.
Director Epen?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye.
Thank you. Motion passes. Next item.
Madam President, in accordance with the district law policies and procedures, I move the Chief Executive Officer be authorized to enter into the necessary contracts and proceed with the purchase of the copier replacements for a total amount not to exceed $46,819.79. This is an approved equipment line item in the 2015 capital budget.
Second.
We have motion and second. Nancy, do we need to elaborate on it?
I'll weigh in just briefly. Every year, our Information Services Department reviews the service call history and page counts and technology usage for all the copiers to identify which equipment needs to be replaced. This year, they identified 13 copiers. These copiers that are marked for replacement service various departments, including nursing, pre-op testing, and the lab. By replacing the older and the more problematic copiers, we improve the efficiency of operations and allow the staff to focus on patient care instead of broken down copiers.
Staff deserves good equipment, too.
Yes, they do.
And unfortunately, just because we're computerizing doesn't mean we're doing without paper copies.
True.
Unfortunately. Okay. Christine, would you take roll call, please?
Director Danielson?
Aye.
Director Nicholson?
Aye.
Director Epen?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye.
You have your approval for your copiers. Next item.
Madam President, in accordance with the district law policies and procedures, I move the Chief Executive Officer be authorized to proceed with the purchase of 5 laparoscopy instruments set for the total amount not to exceed $77,000.
Second.
Do we need-
Okay, the laparoscopy sets that we have are over 7 years old, and they are a mix and match of instruments from 2 separate companies. We believe that by replacing them with sets that are all from the same company, that we can make a major step forward in patient safety. The handles are removable and are not interchangeable from one set to another with the equipment that we have now. Trying to attach instruments from the handles during a case where the lights are turned down is a real challenge for the scrub techs, and certainly wastes time during cases. So I think this is an important step.
Any further comments? Christine, would you please take roll call?
Director Danielson?
Aye.
Director Nicholson?
Aye.
Director Epen?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye.
Motion passes. Thank you. Next item, Dr. Epen.
Madam President, in accordance with the district law policies and procedures, I move the Chief Executive Officer be authorized to enter into necessary contracts and proceed with the purchase of the software and implementation services of the Dragon Medical 360 Network Edition speech recognition for a total additional amount not to exceed $5,667.11.
Second.
We have a motion second. Nancy, would you explain the
This is an
additional?
amount that exceeds the $5,000 limit. And what we're asking for is to be able to pay the taxes on the equipment. That wasn't factored in accurately. So, this is something you approve for us to buy, but I don't feel as though I should go out and just add to it without asking you.
Thank you. We have a motion second. Any further questions, comments? None? Christine, please take roll call.
Director Danielson?
Aye.
Director Nicholson?
Aye.
Director Epen?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye.
Motion passes. Next item, last item.
Madam President, in accordance with the district law policies and procedures, I move the Chief Executive Officer be authorized to proceed with the purchase of 1 new Zeiss Pentero Opme microscope and an upgrade of the existing Zeiss Pentero Opmi microscope for a total amount not to exceed $313,348.
Second.
Do we have a further
Well,
explanation?
once again, we're in possession of antiques. The doctors
Nothing new.
that use this equipment are Doctors Kunwar, Thomas, Eichbaum, Erasmus, and Hensdorf. There are times when two of the surgeons are working in separate ORs at the same time, and they each require a microscope, so we need two. We're asking to upgrade our existing Zeiss and to get a new Zeiss. And it's good to have both of them be the same by manufacturer.
Please take roll call.
Director Danielson?
Aye.
Director Wallace?
Aye.
Director Stewart?
Aye.
Director Nicholson?
Aye.
Director Evening?
Aye.
Thank you. Motion passes. I believe we do have a closed session. This meeting is adjourned to a closed session. Thank you. All right, we are reconvening to open session and reporting there was no reportable action in the closed session. And with that, this meeting is adjourned.